Hi, I'm Rick Barron, and I'm here representing RRNMF, RAF5, and of course, Jayhawks. And I am going to give a 5-minute presentation on pattern recognition of myopathic disorders. The purpose of this pattern recognition approach is to get clinicians close to a diagnosis by recognizing the pattern so that one can accurately diagnose the patient more effectively and lead to management and treatment. So there are 10 patterns in the myopathic disorders, similar to 10 patterns we had in neuropathic disorders. Pattern 1, MP1, proximal limb girdle weakness, the most common myopathic pattern. If it's acute and subacute, it's more likely going to be acquired, and if it's chronic, it's more likely to be hereditary. Pattern 2 is distal weakness or distal myopathy. These can be autosomal dominant, such as in Wieslander or Marksberry variants, or in myotonic dystrophy, or it can be autosomal recessive, such as in the picture in this slide of Miyoshi myopathy. Pattern 3 is proximal arm distal leg. This is the scapulo-perineal pattern. If face is involved, then the diagnosis is FSH dystrophy. Sometimes face is not involved. It still could be FSH, but it also can be other disorders, such as this patient in the slide who's got Pompei's disease or acid maltase deficiency, and Emery-Dreifuss is also in this differential and other congenital myopathies. MP4, pattern 4, is the inverse of pattern 3. This is distal arm and proximal leg. This is the IBM pattern. As can be seen in the pictures on the left, there's finger flexor weakness, quadriceps weakness. This is the classic pattern for IBM. Pattern 5 I call the eyeball pattern. This is various combinations of ptosis and ophthalmoplegia. So if there's ptosis without ophthalmoplegia, myopathies that can do this include myotonic dystrophy and the congenital myopathies. If there's ptosis with ophthalmoplegia, then the diagnosis can be oculopharyngeal dystrophy, such as demonstrated in the elderly lady in the slide, or mitochondrial myopathies or centronuclear myopathies, but it also can be neuromuscular junction, myasthenia gravis, as demonstrated in the young lady on the slide where it's asymmetric, and therefore neuromuscular junction, the eyeball pattern, has diplopia, whereas in if it's myopathic ptosis and ophthalmoplegia, there's often no diplopia. Pattern 6 is the prominent neck and trunk extensor weakness pattern. So you can see on the left this elderly lady with head drop. She has isolated neck extensor myopathy, or INM. This can also happen in the trunk. I think this is the most common cause of pattern 6. Myasthenia gravis can do this as well and present with head drop, and some of the other myopathic disorders as well, but INM is the most common. Pattern 7 is bulbar weakness. Weakness of the tongue, pharyngeal muscles, or diaphragm with dysarthria, dysphagia, or shortness of breath. Causes of this pattern are myasthenia gravis or LEMS, oculopharyngeal dystrophy, and some of the other myopathic disorders. Pompei's disease is also often has very prominent respiratory presentation with the limb girdle pattern, and so that would fit into pattern 7. MP8, episodic weakness, myoglobinuria, and a trigger. This is a pattern that if the trigger is exercise and it's brief exercise, one should think of glycogenoses and McArdle's disease and the other glycogenoses. If it's prolonged exercise, CPT deficiency, and at times mitochondrial myopathies. Some folks just have what I call the couch potato syndrome with exercise. They don't have a metabolic underlying disorder. Some percentage of the population just cannot tolerate vigorous exercise, and they will get pattern 8. Other triggers that are not related to exercise can occur in malignant hyperthermia with anesthetics or certain drugs or toxins or crush injuries. Pattern 9 is episodic weakness that's delayed or unrelated to exercise. This is myasthenia gravis, But this pattern is really up here to talk about the periodic paralyses, either a sodium channelopathy, often hyperkalemia, or calcium channelopathy, hypokalemia, or secondary forms of periodic paralysis such as thyrotoxicosis. And finally, pattern 10 is stiffness and with decreased ability to relax. This is the myotonia pattern. If this is myotonia that improves with exercise, that is a chloride channel disorder, channelopathy. If the stiffness worsens with exercise and cold sensitivity, that is paradoxical or paramyotonia. That is a sodium channel disorder. If the myotonia is associated with fixed weakness, that can be one of the two forms of myotonic dystrophy, or occasionally Becker's disease, or a chloride channelopathy with proximal weakness. So this is the 10 myopathic patterns that you need to be able to recognize in the clinic. And these are summarized in this table, which again is on a laminated card, which is on the opposite side of the nerve pattern. You can carry it in clinic with you to try to get the patient into one of these 10 patterns. Once you have put the patient in one of the 10 patterns, then you can think about what laboratory test to order to get the exact diagnosis and to be able to manage the patient effectively. Thank you, and I hope this REF5 session has been helpful for you in your practice.